Our third research article was a randomized clinical trial investigating couples therapy with alcoholic female patients. Married or cohabitating female alcoholic patients, a sample size of 138 individuals, and their non-substance abusing male partners were randomly assigned to one of three equally intensive interventions. First was behavioral couples therapy plus individual-based treatment. Second was individual-based treatment only. And third was psychoeducational attention control treatment. Participants were heterosexual couples in which married or cohabitating women were entering outpatient treatment for an alcohol use disorder. To be eligible, female patients had to A. be between the ages of 20 and 60, B. have been married for at least 1 year or living with a romantic partner in a stable relationship for at least 2 years, C. meet current alcohol abuse or dependence criteria, D. have alcohol as their primary drug of abuse, E. agree to refrain from drinking alcohol or using other psychoactive substances during treatment, and F. agree to refrain from seeking additional substance abuse treatment except self-help meetings such as AA for the duration of treatment. The findings of the study show that during treatment, participants in the behavioral couples therapy showed significantly greater improvement in didactic adjustment than those in the individual behavioral therapy or the psychoeducational attention control treatment. During the 1-year post-treatment follow-up, when compared with participants who received IBT or PACT, participants who received BCT reported fewer days of drinking, fewer drinking-related negative consequences, higher didactic adjustment, and reduced partner violence. In our fourth research article, the purpose of the study was to determine whether learning sobriety together, a treatment for substance abuse that combines the behavioral couples therapy and individual counseling, had comparable secondary benefits on the internalizing and externalizing behaviors of adolescent versus pre-adolescent siblings living in homes with their alcoholic fathers and their non-substance abusing mothers. In this study, heterosexual couples in which men were entering abstinence-oriented outpatient treatment for alcohol misuse participated in the study. To be included in the study, men had to A. meet abuse or dependence criteria for alcohol, B. have medical clearance to engage in abstinence-oriented outpatient treatment, and C. refrain from participation in additional services except for help self meetings unless recommended by their primary therapist. During a 17-month assessment period, the association between parents' functioning and children's adjustment, as rated by mothers, fathers, and children's teachers, were stronger for pre-adolescents than for adolescent siblings, particularly in terms of children's externalizing behaviors. Recommended interventions for pre-adolescents were to reduce the paternal drinking and improve couple functioning, and the recommended interventions for adolescents was to consider more intensive interventions and evaluation to address internalizing and externalizing symptoms. These on the screen are links to available services in the Bangor area for alcohol abuse. The Community Health and Counseling Services link offers pathways to recovery groups and offers therapy and counseling services for both adults and children. The Treatment That Works link offers listings for local AA meetings as well as area alcohol rehab programs. The person dealing with alcohol dependency or their loved one can call and speak with a registered addiction specialist for advice. The Substance Abuse and Mental Health Services Administration's listing of Maine alcohol and other drug abuse treatment services is a fabulous resource listing available programs across the entire state. As for the adequacy of available services, an alcohol-dependent person may be admitted to the hospital for alcohol-related reasons or other health reasons and while there may be detox per hospital protocol. Once discharged, there may be little to no follow-up concerning their alcohol abuse, and they are sent home to the very triggers that feed their alcohol use. Additionally, there may be too few available programs and providers in the state of Maine to address the large volume of alcohol-dependent people in the state who require help. Thirdly, alcohol-dependent individuals are able to attend AA meetings in this area to receive support towards abstinence. Al-Anon offers support to the spouse or partner of the alcohol abuser. Al-Ateen is a 12-step program for the children aged 13 to 19 years of alcoholics. Support groups may be the only place where family and children of alcoholics can feel that they can receive support from their peers. This can give them the opportunity to overcome the denial that kept them from talking about the alcohol abuse in the first place. In this area, the Bangor area, it appears that there are no Al-Anon or Al-Ateen meetings available for attendance in person, but these programs do offer online support via chat rooms. These chat rooms are moderated by trained officials. Finally, we included a phone number for the crisis hotline available to the residents of Maine. The number is listed there. The service is available 24 hours a day. Also, additionally, see the services and resources links that we provided in the previous slide. Regarding the gaps in services and resources, these gaps exist in services for people at both ends of the spectrum of dependence severity. That is, both for people at the milder end of the spectrum and for those at the most severe end. Few services currently exist for at-risk drinkers and people with functional alcohol dependence. In primary care, very few patients are actually screened, and positive screening results are rarely addressed. Even if an individual is identified in a primary care setting, they rarely seek treatment to address their issue. And according to the CDC, addressing this gap is important because the prevalence of at-risk drinking and functional dependence is much higher than that of more severe disorders. Therefore, these conditions account for the majority of excess morbidity, mortality, and associated costs attributed to alcohol consumption. People with functional alcohol dependence likely require more than brief counseling, but there is a major gap in research concerning optimal treatment strategies. Currently, few services are available for this group because they fall between at-risk drinkers and those with severe recurrent alcohol dependence. More research, especially regarding the effectiveness and implementation of treatment for these individuals, is needed. This research may allow for most people with functional dependence to be treated in primary care and mental health care settings. While most people with functional alcohol dependence eventually recover without any treatment, their period of illness is associated with less severe but still significant dysfunction, such as absenteeism and reduced productivity at work. The early identification and treatment could reduce or hopefully eliminate these costs to the affected individuals and to society as a whole. Gaps in treatment also exist for people with severe recurrent alcohol dependence, the group that most people tend to think of when they think of alcoholism. A recent exhaustive report examining the current treatment system concluded that many of the people providing addiction treatment are not medical professionals and are not equipped with the knowledge, skills, or credentials necessary to provide the full range of evidence-based services to address addiction effectively. Additionally, addiction treatment facilities and programs are not adequately regulated or held accountable for providing treatment consistent with medical standards and proven treatment practices. No other chronic disease is treated with brief stints in a program with limited follow-up care. Instead, for other chronic conditions, patients are followed closely by physicians and other professionals over long periods of time with the goal of minimizing symptoms and relapses, treating complications, and maximizing function. This does not typically occur currently in dealing with severe recurrent alcohol dependence. So what do NPs need to gain from this, and how will we apply it to our practice? First, we need to foster trusting relationships in order to recognize if our patient has a problem with alcohol. Second, to use appropriate screening tools such as CAGE, Audit, or SBIRT. And here we've attached a link to access these various tools. Third, identify the underlying risk factors or problems for alcohol abuse. Fourth, identify family strengths and resources. Fifth, offer education and support for the alcoholic and for family members. And sixth, be active in the community at the state and at national levels to increase the awareness and services for families dealing with alcoholism. And finally, in conclusion, every NP can expect the frequent contact with persons who are directly or indirectly affected by alcoholism. The negative effects of alcoholism are felt by the entire family, not just the victim of the illness. The effects of alcoholism in families are difficult to overcome, yet with the appropriate approach and support, positive steps can be taken to improve lives. Encourage the use of available resources and tailor interventions to accommodate the family situation to improve positive outcomes. Finally, we have our questions for discussion. Choose one or two out of these questions in order to discuss. One is, when screening patients for alcohol dependence, how can nurse practitioners encourage patients to give honest responses to the screening questions? Second, some patients who are pregnant do not see any harm in having an occasional drink. What advice would you give to the patient in clinical scenario 2 that we have described above? And third, using the links attached in our resource list, develop a list of options and initial plan of action for one of our case scenarios. And then we have our references. Thank you. Hope you enjoyed.